Okay, Assalamu alaikum and a very good morning. So, our today's session is basically in continuation with the treatment of RCC and metastatic RCC. So, in the previous lectures, you might have encountered studying the removal of a localized disease. But in this session, we are going to discuss specifically about locally advanced resectable disease. So, this is a very hot topic, as you know, for all the exam aspirants. So, whatever knowledge we are going to deliver in this particular lecture would be of utmost importance in your upcoming exam. So there are some things that we are going to discuss regarding the locally advanced RCC. Firstly, before going forward with this, you need to understand that you need to have a proper imaging, the ECOG status of the patient. You should know about that as well. You need to have proper counseling regarding whatever we are going to do to the patient. How would the patient fare post-operatively? So, Dr. Eliha would going to go forward with this presentation. Dr. Elia.
Assalamu alaikum everyone. So we are going to discuss the treatment of locally advanced resectable disease today. Locally advanced RCC is defined as the tumor that extends beyond the kidney to nearby tissues or structures such as adrenal gland, renal vein, perinephric fat surrounding lymph nodes. However, it has not metastasized spread to distant sites like lungs, liver, bone, or other organs. So basically, we are going to discuss the T3 and T4 disease patients. The T3 stage is T3 of the is include the tumor extend into the major veins or perinephric tissue, but not into the ipsilateral adrenal gland and not beyond the Girota's fascia. It further is divided into T3A, B, and C. The T3A is the tumor extend into renal vein or its segmental branch or tumor invade the pelvic lesion system or invade the perirenal and or renal sinus fat, but not goes beyond the Girota. T3B is the tumor extending into IVC below the diaphragm, and T3C is the tumor extends into the IVC above the diaphragm or invade the wall of IVC. While T4 is the tumor invade beyond the Girotas, including contiguous extension into the ipsilateral adrenal. So this is the pictorial representation of T3 stage, T3A, in which the tumor involves perinephric tissue, while in T3B, the tumor involves renal vein or IVC below the diaphragm. And in this picture, the tumor involves the renal vein IVC above the diaphragm. Next is a regional lymph node involvement, and X is the regional lymph node which cannot be assessed, and 0 is no regional lymph node mets, while N1 is metastasis through regional lymph nodes. So our learning objectives are the adrenalectomy and RCC, lymph node dissection, thrombectomy, and en bloc resection. Adrenalectomy in RCC, the multivariate analysis showed that upper pole location was not predictive of adrenal involvement, but rather the tumor size. The radiographic and intraoperative findings should be the guiding tool for removing the adrenal with RCC. So the clinical indicators of adrenal involvement are: number one is the diffuse involvement of the gland by the tumor or the large tumor size of more than 10 centimeters, extrarenal tumor extension, tumor thrombus, regional lymphadenopathy, regional metastasis, and adrenal mass on imaging. The summary of evidence said that ipsilateral adrenalectomy during radical nephrectomy or partial nephrectomy has no survival advantage in the absence of clinically evident adrenal involvement. So it is the level of evidence is 3. Do not perform ipsilateral adrenalectomy if there is no clinical evidence of invasion of the adrenal gland. It is a strong strength.
So, the excision of the adrenal is really important, and the operating surgeon, should know when to take out the adrenal and when not to take out the adrenal, and what are the indications of an adrenalectomy during an RCC surgery. So, anybody has an idea what are the indications, two, three indications at least, to how to manage an adrenal during a radical nephrectomy?
On imaging, adrenal is directly involved, then we have to take out the adrenal gland. Or if the tumor size is more than 10 centimeter, then adrenal gland can be taken out. Further, as Dr. Alia has already mentioned, in the presence of tumor thrombus or clinically evident regional lymphadenopathy.
So all the tumors that are more than 10 centimeters, do we need to take out the adrenal?
No, I think
So yeah, it should be the upper pole mass that is more than 10 centimeter. Or the surgeon, even if the CT does not tell you, but the operating surgeon finds that the needle might be involved during the surgery, you need to take that out. The upper pole tumor more than 10 centimeter. If the adrenal has a problem during the CT scan when it was reported, or the surgeon finds that the adrenal is actually involved grossly by the tumor, then you need to take that out. And all the other points that Dr. Elia has mentioned, those are also the indication to take out the adrenal. But those are mostly CT findings, the the imaging findings, basically.
You see, it's not the size, it's the site that is most
Yes,
important.
sir, the upper.
And the second thing is, if you are going through your procedure on an open platform, then the palpability of the adrenal is of utmost importance. So it's always at the back of the hand of the operating surgeon, whatever that surgeon thinks, it's always prudent. The second thing is, when you go on to something like away from the tumor, that is, your hands are not within the body, you are doing it minimally invasively, for instance, laparoscopy or robot, then the tactile sensation is not there. What replaces the tactile sensation is something which is very simple, and that is ultrasound. If you don't have the intraoperative ultrasound, then you are in no position to say that this is an adrenal which I want to leave. The problem with these kind of tools is the surgeon is going ahead without having the whole armamentarium. So you are at a loss somewhere down the line if you are not properly reading the whole chapter, because there is something written in the parasynthesis, in the downward lines. So read the whole chapter, and there is something which is in a finer point, and that is intraoperative ultrasound, which is not here.
Definitely, sir.
Lymph node metastasis and excision. Lymph node metastasis, the patients with two or more of the following pathological features are found to have increased risk of lymph node metastasis of more than 40%. These includes a large primary tumor size, clinical stage of T3 and T4, high tumor grade, sarcomatoid features, and histological tumor necrosis. Lymph node mets. The presence of lymph node metastasis is an important prognostic factor and defines a high risk subsets of patients with advanced RCC. Although lymphadenectomy for RCC provides accurate staging, the therapeutic benefits of routine lymphadenectomy is controversial. Even in patients with radiographic adenopathy, only 30 to 43% of clinically enlarged lymph nodes contain metastasis disease. Less than 20% of suspected metastatic nodes, clinically positive nodes, are positive for metastatic disease at histopathological examination for.
Again, if you go back to the same slide, the references here are put which are slightly outdated.
Yes.
You see, this was something which everybody was missing, the whole picture. Because again, with the advent and the placement of laparoscopy, people were going towards tumor nephrectomy. They were not going towards something called template dissection of the lymph nodes. So the classical definition of radical nephrectomy was lost. It was just nephrectomy. And that was the very basis of something called prognosis in follow-up, because these patients were not doing properly in follow-up. They were presenting with metastasis, they were presenting with recurrences, just because of the reason that the lymph nodes were not taken out. So in early 90s and before that, it was all template dissection. And that somehow benefits these 30% of patients which were actually lost in this whole milieu of non-invasive, of minimally invasive surgery. So we have come back to the same point after 2020. Now the guidelines are that you have to do something called, again, palpability of the tumor. Palpability is lost, then you have to have something which is like go back to the back benches, see the CT scan on the console, see for yourself which are the lymph nodes that are doubtful. Take out those lymph nodes. It's never a case of tumor nephrectomy now. So you have to put this point in this slide, otherwise the message is wrong.
So initially, the surgeons, like Dr. Asad said, the surgeons were not removing the lymph nodes. And the surgeons who were actually removing the lymph nodes turned out that those lymph nodes were metastatic in that case. So in order to take out those lymph nodes, it is important that those lymph nodes should be either taken up by the CT scan, they are pathological, or the surgeon finds firm enlarged lymph nodes during the surgery. That is important. There was another article I was reading that what if it is a clinically negative lymph nodes over there and the CT does not pick it up? So do we need to take out the chain of lymph nodes even then when those lymph nodes are not palpable?
Again, it's a matter of controversy, and the controversy is taken care of by something which Haris will be talking about in Eurocon. There is an ultrasound which is now available, and that is a drop-down ultrasound probe. A drop-down ultrasound probe is something which is a kind of a bullet. It has got a cord attached to it, to its tail. You put it through a port. You drop it down. You get hold of it through a kind of, for instance, a forceps, and then you put that ultrasound over which area you want to survey. And then you get hold of everything in front. If you write down when you are doing excision of the tumor. So it's something which is not read 1 month back when you have seen the CT scan. It is down at that point when you are taking the kidney out. So you always go towards the template, see the template through the eye of the ultrasound probe, right? So all those people who are interested in having tumor nephrectomies as surgeons, they have to have a kind of extra skill, and this is mandatory for all surgeons working in Europe as well as in UK to get this skill with themselves. Otherwise, they can't operate now, whether they are robotic surgeons or they are laparoscopic surgeons. They can't operate on tumors, kidney tumors, unless and until they know how to do an ultrasound intraoperatively.
So one thing that is more important is that lymph node dissection is not therapeutic. It would not have any sort of like, the overall survival of the patient would not increase if you take out the lymph nodes, even if they are clinically there. So you only take out the lymph nodes for staging purposes and also for prognostic purposes and not for therapeutic purposes.
See, the paradigm is changed. Now the only option for kidney tumor is not surgery. There are other things. They are immune checkpoint inhibitors now. So you have got things in adjuvant setting, things in new adjuvant settings with kidney tumor. This wasn't the case 20 years back.
Right, definitely. So this is a template that we have devised.
Okay, so common sites for nodal mass for right-sided tumors, the most common site is intra-aortic cable lymph nodes, while for left-sided tumors, the common site is para-aortic nodes. So the templates, the Dr. Asad are saying, and for right-sided tumors, remove the para cable, intra-aortic cable nodes from crus of the diaphragm to the common iliac artery. While for the left-sided tumors, it's again the removal of the lymph nodes from para-aortic, inter-aortic cable lymph nodes from the crus of diaphragm to the common iliac artery.
One more thing. For instance, we are all urologists. We want to train ourselves. We want to train ourselves through different purposes for different matters, and we do different things. For instance, we are transplant surgeons. We are vascular surgeons. On a flip side, one technique actually adjust ourselves into another realm also. For instance, if you do template dissection properly as an oncological surgeon, you will be in a better position to do RPLND when you are dealing with testicular tumor. You see, there is an advantage both ways. If you shy away from template dissection, you will not be able to do it either in the pelvis in the context of carcinoma bladder, or you can't do justice when you are dealing with something called RPLND. You are always going towards lumpectomy. That is not the case. Lumpectomy is different from RPLND. If you want to do RPLND, practice yourself in this template fashion.
True, sir.
One practice adds to another way.
Very true, sir.
Lymphadenectomy. So this is the EORTC 30881 randomized trial of lymphadenectomy. At radical nephrectomy failed to show a survival advantage for most of the patients undergoing lymphadenectomy with lymph node mets were present in 4% of the patients undergoing complete lymph node dissection. However, a large European study of 1983 patients suggests better cancer-specific survival in patients with large bulky tumors and sarcomatoid features when a more extensive dissection of lymph node was performed. Therefore, lymphadenectomy may be performed in patients with clinically suspicious lymphadenopathy for staging purpose. It should not be performed routinely in patients with localized disease and clinically negative nodes. The recommendations for the lymph node dissection are: do not offer an extended lymph node dissection to patient with an organ confined disease. It's a weak strength rating. And patients with clinically enlarged lymph nodes perform lymph node dissection for staging, prognosis, and follow-up implications. It has a weak ratings.
Sir, what is your take on clinically negative nodes? Can we do a template dissection in those particular nodes because we already know the extent? So can we take out those lymph nodes if they are clinically negative?
Again, it's a matter of controversy these days. There is a debate whether they are helpful or not. But sometimes what happens is there is a term called field cancerization. So if something is happening now in terms of gross involvement, it might be possible that there is something which is like a microscopic involvement, which we will not be able to see here. Now, here comes the other technology, for instance, confocal microscopy. If you have got confocal microscopy, you will be able to judge yourself within 5 minutes where you are, whether it's weak or whether it's a negative or a positive node that you are dealing with. So very soon we'll be able to do immunofluorescence guided surgery or confocal microscopic guided surgery. So these are the days which are not very, very far. They are just around the corner. Maybe next year, 2026. Exciting year.
Hopefully.
Move forward towards the thrombectomy. The IVC involvement. One of the unique features of RCC is its intraluminal growth into the renal vein circulation, also known as the tumor thrombus. The tumor thrombus remains attached to and continuous with the primary renal mass. 45 to 70% of the patient with RCC and IVC thrombus can be cured with radical nephrectomy and IVC thrombectomy. The tumor thrombus formation in RCC patients account for 4 to 10% and may involve renal vein up to 78.3%, subdiaphragmatic IVC 16.4%, or supradiaphragmatic RPC 5.3%. So this is the picture showing a renal mass which is involving the IVC more than 22 centimeters. So the IVC thrombus should be suspected in patients with renal tumor developing lower extremity edema or isolated right-sided varicocele. Microscopic invasion of wall of IVC is also a strong predictor of cancer-specific survival. The diagnostic study of choice for IVC thrombus is MRI. This is the Mayo classification of IVC thrombus, which states level 0 to level 4. Level 0 is the one in which thrombus is limited to the renal vein. Level 1 is thrombus in renal vein and IVC within the 2 centimeter of renal vein ostium. While level 2 is a thrombus which is involving the renal vein IVC more than 2 centimeter from the renal ostium but below the hepatic veins. Level 3 IVC thrombus is the one which involves the IVC above the hepatic veins but below the diaphragm. And level 4 is when the thrombus involves the IVC above the diaphragm.
One more thing, when you encounter an IVC thrombus, as Dr. Elias mentioned, that even if you've gotten a CT scan, it is utmost important that you should also get an MRI, because in MRI you can actually find the exact tumor extent and the wall invasion in more detail rather than the CT scan. And that particular MRI should be done within 1 to 2 weeks of surgery. It should not take that long, because the tumor, the renal tumor can actually progress really fast. So it's not like you have gotten an MRI and then you're planning a surgery after a month or 2 months, because after that, that particular MRI would be redundant. You need to get an MRI within 1 or 2 weeks, and specifically if you find an IVC thrombus, because that would give you more detail of how to deal with that particular disease. So do you have any
Yes, and MRI, MRA
MRI,
is
yes,
more
more
pertinent,
pertinent?
MR angiography, because it has got more resolution, and the upper part of the body, it has got more resolution as compared to the other areas, that is central abdomen. So either in the pelvis or in the upper abdomen, MR has got its value.
So do you think that the timings is also something that we should
Very
take into
important.
account?
Yes, if you are going towards a thrombectomy and you don't want to change the stage of the disease, it's very important, particularly with robot.
Particularly with the robot, yes.
Yeah.
Moving towards the management of IVC thrombus. So for level 0 thrombus, which I have told that it is up to the renal vein, we can apply the clamp, vascular clamps or Stansky, and we can take it out. Management of level 1 thrombus, which involve the IVC less than 2 centimeter from the renal vein ostium. So for the management of this, we have to apply the Stansky clamp, but we have to make sure that the circumference, the lumen of the IVC should not be completely blocked. For management of level 2 thrombus, which is more than in up to more than 2 centimeter from the renal ostium and below the hepatic veins. So the thrombus managed by sequential clamping of lower IVC, contralateral renal veins, cephalate IVC, along with the mobilization of IVC and occlusion of lumbar veins, allowing for vascular occlusion. So these are the points which showing the distal clamp, proximal IVC clamp, and the opposite side renal venous clamp.
So in this kind of situation, I'm sure a lot of you, even the consultants and also the residents, might have heard of sequential clamping, which is is a very hot topic amongst the examiners at least. So anybody can give me an idea what is sequential clamping during the surgery, and how do you apply those clamps, and what is the sequence, and what is the sequence of clamping and declamping? Anybody from the residents? Anybody wants to come forward? I'm sure a lot of us do open IVC thrombectomy surgeries. And is there a difference between when you're dealing with a right-sided tumor and a left-sided tumor? Anybody wants to come forward and tell me about it?
Right. So
Yes.
again, so if you are practicing in one area, that is transplant, then you will be able to do many things again. For instance, certain C clamps. So if you go back one step back, one slide back, where there is a Siuteducation clamp, piche. Now, if you have applied the Siuteducation clamp, then if you want to release it, which part of the clamp will be released first? The proximal most part or the distal most part, जो उसका सबसे आगे वाला एंड है, वो पहले खुलेगा या पीछे वाला एंड पहले खुलेगा? लॉजिक क्या कहती है? कोई ना कोई कॉमन सेंस है तो आगे वाला। तो ये सीक्वेंस में वही चीज आ रही है ना। तो अगर आप अगले वाले उस पर चले जाएं तो यहाँ पे पहले का कौन सा खुलेगा?
सुपीरियर।
तो आगे वाला। So there is an analogy, there is a similarity. So you see, science is never something which is like coming from Mars. It is there on planet Earth. It's common sense. So this is known as sequential clamping and sequential declamping. When you want to clamp something, There is always something which is clamped first, the end, and the other end is clamped later, slightly later, maybe half a second. But when you want to declamp it, the clamped portion which is done at the very end should be declamped in the first instance, and then again you revert back.
So there's a very classical teaching. If you're dealing with a right-sided tumor, for example, let's suppose what you need to do is when you encounter thrombus like this, you always clamp the distal IVC first. And then you go to the contralateral vein and then the superior IVC. And this is what we do basically for a right-sided tumor. This is what we do basically as for a right side. What if there is a left-sided tumor? Would you clamp the right renal vein? And if you clamp the right renal vein, so what things can you encounter? What will happen? Is there a difference between the anatomy of the right kidney and the left kidney according to the venous drainage? Anybody has an idea? Help me, somebody. Somebody from the back? Yes.
Right renal vein is short as compared to left renal vein, and there are gonadal vessels draining directly into IVC from the right sides, and in left renal vein, gonadal vessels are drained.
So would you clamp the right one as well if you're dealing with a left-sided tumor?
Yes, if the IVC involved, then we should.
Okay, so any idea about how you would put the clamps? Sequential clamping? Any idea? Should I go about telling how to put the clamps and how to declamp that IVC?
Again, there is a very peculiar kind of an example.
Yes.
फॉर एग्जाम्पल आपके एक कमरा है, उसमें किसी ने आपको कह दिया कि इसमें एक चोर दाखिल हो गया। तो चोर जब दाखिल होता है तो सबसे पहले क्या करता है? तो आप पहले चोर बन के सोचें। अगर आप चोर हैं तो आप सबसे पहले क्या करेंगे? कईयों साहब, आप चोरी की गरज से, नीयत से कमरे में दाखिल हुए, तो अगर आप अक्लमंद आदमी हैं तो आप क्या करेंगे? ऐसे
माइक दे दो भाई, माइक।
पहले माइक लेंगे। ये कौन सा चोर है?
सर,
आप सारा दिन मूवियां देखते हैं, ये जेम्स बॉन्ड, ये बॉन्ड, वो बॉन्ड, तो ये बताइए वो जेम्स बॉन्ड करता है क्या है सबसे पहले? वो भी तो चोर ही है। अंग्रेज आए थे हिंदुस्तान, क्या किया था उन्होंने पहले?
तिजोरियां लूटी थी।
नहीं, उससे पहले एक और काम किया था ना, वो आप भूल रहे हैं। एग्जिट स्ट्रेटेजी। एग्जिट स्ट्रेटेजी हर चोर पहले देखता है कि मैंने भागना कहां से है। वो चोरी क्या, जिसको ये नहीं पता हो कि भाई ये कोई आप किसी मुल्क पे कब्जा करने आए हो, अपने आप को खुद कुछ धमाका करने थोड़ी आए हो। तो इसलिए पहले भागने का रास्ता तलाश करते हैं। अब आप बता दीजिए। तो ये तो कच्चे चोर हैं सारे।
Okay, for example, you're dealing with a right-sided tumor. What you need to do is first apply the clamp distally. Okay, so when you apply the clamp distally, you're basically stopping the inflow, right? And then you go on the left-sided renal vein. Why do you need to go on the left-sided renal vein? Because when you clamp it, and even if there is any kind of manipulation, then you don't want that the tumor thrombus to actually go into that the contralateral renal vein, and then you also apply it on the superior IVC. And after, when you have done this, then you do a cavotomy. Firstly, you take out the thrombus and then you irrigate it with heparinized normal saline. One of the things that is very important whenever you're doing a sequential clamping, you need to involve the anesthetist. You don't do it without telling the anesthetist, because you need to tell them that you're going to do a sequential clamping, you're going to do a cavotomy, and at that time, whenever you clamp the IVC, there might be hypotension, and the patient might need intravascular volume. And even before clamping, you need to tell that to the anesthetist so that the anesthetist knows that the intravascular volume is adequate. The patient is hemodynamically stable. And after telling that, then you perform the surgical maneuver, not before that. And even before clamping, the intravascular volume should be adequate. During clamping, the anesthetist should make sure that the patient is not hypertensive. If there is, the anesthetist might keep him on vasopressors, right? And even after you have declamped, even then you need to communicate with the anesthetist in order to know that the intravascular volume is adequate and the patient is hemodynamically stable. So always talk to the anesthetist before you do this maneuver. It's not something that you can just do on your own and just expect the anesthetist to do whatever they want to do in that particular situation. So so after the chemotomy, what do you do? Once you take out the thrombus, then you don't repair the IVC completely. What you need to do is you need to declamp the superior IVC first, let all the debris drain first because of the black backflow, and all the air and all the debris will be removed. After that, then you close it. And then sequentially, you remove the clamp of the contralateral vein, that is the healthy kidney, and then the inferior clamp that you've put on the distal IVC. So for the right-sided tumor, you go anti-clockwise first, and then when you declamp, you go clockwise. So one of the things I was reading, that what if you encounter a left-sided tumor? Would you clamp the right-sided renal vein? Because on the left side, you have a lot of collaterals coming into the kidney, but on the right side, the renal vein is short and it is directly draining into the IVC. So is there an indication to clamp that renal vein on the right side, or you can do an IVC thrombectomy without it? So because if you clamp the right-sided renal vein, you might encounter congestion in that particular kidney. So any comments on this? Can we do an IVC thrombectomy without clamping the right-sided renal vein?
Right side renal vein is slightly lower than the left, maybe.
So basically it depends. What is the extent of the IVC thrombus? So according to what I have read, so it's not that important to clamp the right-sided renal vein if you can take out the tumor thrombus without it, because it lacks the collaterals that the left side has. So even if you want to clamp the right-sided renal vein, you do it for a very short period of time, and you do it very late in the procedure. And you have to release the clamp earlier than all the other clamps, the superior and the distal. So according to this, it's not necessary that you clamp the right-sided renal vein because of the congestion that you might encounter.
So this is the picture which showing the venous patch, and this is the Dacron and PTFE graph. Thank you so much.